Uh, uh, so, so starting with like like in last class we discussed about hypothyroidism and Graves' disease. So going ahead to moving, there's thyrotoxicosis. So it's a hypermetabolic condition which is caused by an inappropriately high level of the circulating thyroid hormones, irrespective of the source. And to the etiology, it could be because of increased endogenous secretion or because of an increased amount of exogenous secretion. When we say endogenous secretion, it could be because of a hyperfunctioning thyroid gland. One of the most common causes of thyrotoxicosis includes Graves' disease. The other causes could include toxic multinodular goiter, toxic adenoma, or a TSH producing pituitary adenoma. And the exogenous causes include it could be because of excessive replacement of excessive replacement therapy, like if the patient is consuming excessive amount of levothyroxine. This could lead to a state of hyperthyroidism and further thyrotoxicosis. Uh, Other than that, endogenous secretion includes one more parameter, which is the destruction of the thyroid gland, which could be thyroiditis. It could be drug induced, drug induced, or it can be because of radiation as well. And some rare causes includes it like gestational trophoblastic neoplasia, or because of some sort of mutations in the TSH receptors, or because of a metastasis of thyroid cancer. Rarely, these causes can also lead to thyrotoxicosis. Uh, the effects of thyrotoxicosis, in including the symptoms of hyperthyroidism, which includes the heat intolerance, excessive sweating, increased bowel movements, as discussed earlier, or because of any pretibial myxedema, manifestations of Graves' ophthalmopathy. In addition to this, uh, thyrotoxicosis causes a state of generalized hypermetabolism, that is increased. Basically, there are increase in the number of sodium potassium ATPase pumps, which results in an elevation of the basal metabolic rate. And add to that, there'll be an upregulation of the adrenergic receptors, causing an increased stimulation of sympathetic nervous system. There'll be cardiac effects as well, wherein there'll be an increase in the number of ATPase channels on the myocytes, because of which there'll be an increase, like the sarcolemmal transsarcolemmal calcium movements will increase, because of which the myocardial contractility will increase. And there'll be an additional decrease in the peripheral vascular resistance as well. So all of this will contribute to features of uh, tachycardia, palpitation, irregular pulse. It can also result in complications like atrial fibrillation, and there can be thyrotoxicosis induced cardiac failure as well. And sometimes patients can come with the complaints of chest pain. And the other symptoms, again, are similar to that of that's seen in hyperthyroidism, which includes musculoskeletal manifestations of fine tremors, or there could be osteopathy or myopathy as well. And again, from a reproductive and point of view, females can have the amenorrhea, or anovulatory infertility, and males may have infertility, erectile dysfunction, and uh, gynecomastia as well. Further, we had I had completed the first term, which was that of Graves' disease, and after that, to further evaluate, we can go ahead and again start with measuring the thyroid function test. Then there we'll see a decrease in the TSH level, and increase in the so there'll be an increase in T3 T4 levels and a decrease in TSH levels. Here we can consider overt hyperthyroidism, and if the TSH levels are decreased but T3, T4 levels are normal, then again there can be subclinical hyperthyroidism. So if the characteristic features of grave disease are not present and the anti thyroid receptor antibody comes out to be negative, then we'll go ahead with the scintigraphy technetium 99 scan. And this, if that scan shows a high uptake and a diffuse pattern, we establish Graves' disease. Whereas if there is a high uptake in a nodular pattern, then we can suspect toxic adenoma or multinodular goiter. Furthermore, if there is low uptake, then we go ahead and check the anti-TPO or anti-TG antibody levels. And here, if there is a high uptake, then we can if it's positive, then we can suspect Hashimoto's thyroiditis. And Hashimoto's thyroiditis can also lead to toxicosis, which is Hashitoxicosis. And if at all it is negative, then we go ahead and measure the thyroglobulin level. If it is high, then again the causes of endogenous hyperthyroidism, which could be thyroiditis, or low, it could be any uh, like excessive replacement therapy if the patient is taking that. If the TSH and T3, T4 levels are normal, like we can go suspect rare causes of hyperthyroidism, which could be beta HCG associated hyperthyroidism, which can be seen in cases of trophoblastic neoplasia or in cases of hydatidiform mole diseases, or even in case of gestational thyrotoxicosis. Uh, Going to the treatment of thyrotoxicosis, uh, the treatment will have 4 arms of approach, which includes the symptomatic management, the anti-thyroid drugs, which we'll be using, radioactive ablation, and thyroid surgery. So, in case of symptomatic treatment, these patients are at a very high risk of developing cardiac complications such as atrial fibrillation or heart failure. So, it is essential to control these hyperadrenergic symptoms, and we can start the treatment by using beta blockers, and which will provide control of these symptoms, and in additional the neuropsychiatric symptoms will also be controlled. And the treatment option will include using beta blockers, which is amongst which the first line drug which we may consider administrating is propranolol. The alternative drugs that we could use are atenolol or metoprolol. And in case of severe thyrotoxicosis, or it needs to, which is being treated in the ICU, you consider administrating esmolol. And furthermore, if the patient has developed any cardiac complications, you will go ahead with like management for like the complications could include atrial fibrillation or heart failure, and both should be managed accordingly by rhythm and rate control, and giving adequate resuscitation. Uh, then the Yes, sir.
What medication do you use when there is atrial fibrillation?
Sir, in atrial fibrillation, sir, like you have 2 arms, sir. Like there'll be rate control and rhythm control, sir. So, like for rate control, you could like basically you are targeting a rate of less than 100, and so you can use beta blockers, which is metoprolol, atenolol, which are these are the first line drugs, and these are also preferred if in atrial fibrillation due to hyperthyroidism. Or if at all beta blockers are not there, you can also use calcium channel blockers like diltiazem or verapamil, sir. And
No,
sir,
you have to use amiodarone. The advantage of amiodarone and, for example, you said initially propranolol. The
yes,
advantage
sir.
that is apart from reducing the positive chronotropic and inotropic effects of the thyroxine on the heart, they will bring down the, as you said, bring down the heart rate, and also they will bring down the contractility of the heart and rest the heart. So that is important. But in addition, both uh, um, propranolol and amiodarone have the added benefit of preventing peripheral conversion of T4 to T3, which is because
Yes, sir.
T4 is the inert form, but not inert, but less active form.
Less active form. Yes, sir.
So peripheral conversion of T4 to T3 will be reduced. So for that effect, if you want, if the patient is in heart failure, you can also add corticosteroid, which will also have similar effect of preventing peripheral conversion of T4 to T3.
Oh, okay. Yes, sir.
Okay, carry on.
Yes, sir. And like after having this symptomatic management, we'll go ahead with the definitive therapy, which will include administrating antithyroid drugs, radioactive iodine ablation, and thyroid surgery. When we in case of antithyroid drugs, they are usually effective in rendering a patient and giving a patient a euthyroid status, uh, and the like we consider administrating medications which can belong to the thiamide groups, which includes methimazole, carbimazole, and propyl thiouracil. And other than that, like the indications will be if the patient uh, like in the initial management, as well as to prevent in case of prior to surgery, it is, or in case of before administrating radioactive iodine ablation, we consider giving antithyroid drugs because it is essential to achieve a euthyroid status. In patients who if the cause of thyrotoxicosis is Graves' disease, and if there is a high likelihood of remission in these patients, we'll consider here also. And in cases where surgery and radioactive iodine ablation is contraindicated, those are the cases where we'll go ahead with antithyroid medications. And here, the
How do
most
drugs work?
uh,
Go
sir,
on.
we have thionamides, which includes this methimazole. So inhibits thyroid hormone production by inhibiting thyroid peroxidase. So the further conversion, like there's further blockade of the entire cycle of iodide oxidation, organification, and coupling process. And the other one is propyl thiouracil. This will act by lowering the peripheral conversion of T4 to T3, sir, by inhibiting the deiodinase enzyme, sir.
In addition, I think the propyl thiouracil is the most powerful drug because in addition to the peroxidase prevention of or inhibition of peroxidase, it will also prevent peripheral conversion of P4 to
Con-
P. So,
ye-
we are trying to, for some reason, propyl thiouracil is not very popular in India. It wasn't even available. Now it is available. But speaking to the endocrinologists, they say it is a bit toxic. So
Yes, sir.
they tend to use they tend to use if the patient is mildly hyperthyroid, you use carbimazole. If they are much more strongly hyperthyroid and you need to achieve euthyroid status early, or you want to prepare them for surgery or radioiodine, or if the patient is hyperthyroid and they have some other condition which needs surgery, then you tend to use methimazole. How long do you need to give methimazole before you achieve some, let us say somebody's um, TSH is very low and their free T3, T4 is very high. How long do you need to give them treatment before you can achieve euthyroid status?
So usually patients achieve remission within 1 to 2 years, and I read that
Yes,
you titrate the initial dose.
2 years. You take
Yes,
that
sir.
long, you take that long to achieve euthyroid status.
No, like sir, no, sir. If we are assuming the cause to be Graves' disease, sir, like depending on the cause, sir.
But, that,
Uh,
but let us say it is Graves' disease. How long do you want before you can get the patient to be euthyroid?
so the permanent remission is 1 to 2 years, is what
Permanent.
I
We
read.
are talking about permanent. Permanent, of course, in the sense you have to keep giving the medication. Let us say they are
Yes, sir.
hyperthyroid now. You want to make them euthyroid. How long do you usually need?
Uh,
Anybody else?
3 months,
Do
sir.
we check 6 to 8 weeks, sir?
Who
Like
said 3
repeat.
months? Who said 3 months?
Sir, me. Vinod, sir.
Nikita and Praveen, what is your answer?
Sir, 4 to 6 weeks, sir.
Nikita? She's not there. She's in
She's on duty today, sir.
emergency, na?
Yes, sir.
1.
Okay. See, I think Praveen is right. Minimum, I think you are also right, Samya.
Yes, sir.
Minimum 4 to 6 weeks, ideally 6 to 8 weeks. So if somebody needs surgery, for example, there was a recent situation where we had a patient who had a maxillary cancer who needed to be operated, and he was hyperthyroid. So me and Sanjay managed it jointly, and in about four weeks, they brought it down to euthyroid state, and then he was operated. But generally, it is 6 to 8 weeks, even up to 10 weeks before the patient becomes euthyroid. Then
So
maintain.
just,
Huh.
but like Einass said, sir, Graves' disease will have remissions and flares up, no, sir. So I think in
I
what
didn't see that fact at all. See,
no, sir.
it is not a permanent solution. I added that. See, for example, she herself said, and Niranjan will also agree, I think basically drugs are not the answer for hyperthyroidism. When especially if it's due to Graves' disease. Either you have to operate on them or you have to give them radioiodine. So those are
Yes, sir, I agree. It is only medicines are only for to control the initial this thing, and eventually you have to go for either radioiodine or surgery.
correct. That
Yes,
is
sir. But in patients like autoimmune with Graves' disease and all, first we have to get them to euthyroid state to
Yeah, yeah.
operate, no, sir.
Yes,
Because with
yes, that is
hypothyroid, we
absolutely
cannot.
right.
So that is
So
the
patients with
period is 6 to 8 weeks. You will get them. Very rarely. See, in addition, you will have to give them propranolol, corticosteroids. If the patient is in atrial fibrillation, you have to give amiodarone. All those things are there. But by and large, you will be able to achieve euthyroid status with maximum of 10 weeks. 8 to 10 weeks, you will get it. And then you have to immediately, decide if it is Graves, depending on the age of the patient and preference of the patient, you either operate on them or you give them radiology.
okay, sir.
Sir, one doubt I had was that amiodarone is used, sir, in management of atrial fibrillation and like if it is caused by this, but it is also considered to be a cause of. Is it like considered to be a cause of drug-induced thyrotoxicosis? Like if we have contrast-induced or drug-induced.
Yeah. But see, you are not giving it alone. See, you are giving it
Okay.
specifically for the purpose of atrial fibrillation. So you are adding other medications also. So that is why then it will be all right.
Okay. I'll go ahead, sir.
Yeah.
Yes. Yeah. So in terms
So
of
one doubt, sir. Sir, amiodarone causes hypo or hyper, sir?
I am not sure whether it causes hyperthyroidism. I don't know.
Hypo only, no, sir.
No, hyperthyroidism. It is iodine
Hyper.
compound.
Hypo.
No,
Hypo,
hyper,
no?
ma'am.
Amiodarone, sulfonylureas,
No, ma'am.
thalidomide are all hypothyroidism, no?
No, ma'am. Hyperthyroid. Amiodarone contains iodine, which is access hyperthyroid.
So that okay, I'll check once, sir. I'll check. I thought amiodarone was a known cause of hypothyroidism. I'll find out, sir. I'll find out.
Yeah. Okay.
Yes, sir.
See,
Then yes, sir.
you need to know the mechanism of action, the dosage, how you administrate, what are the complications associated with it. Because in the exam,
Yes, sir.
if you get hyperthyroid patient,
Yes, sir.
there will be limited number of questions. See, for example, the initial symptoms and signs, somebody will ask for one candidate, then they will ask for the eye signs and everything, and then they will come to medical management and the drugs. So you need to know the details of how you give, how much, when do you start, What is the dosage? We should know.
So like
So, sir,
so with the
amiodarone
dosage,
in fact causes both apparently the hypo and hyper. Both it is associated with both.
Okay. So that is why
Okay,
I
sir.
think it has to be given along with something. You can't give it here specifically. You are addressing the issue of atrial fibrillation. If you give it, the added advantage would be it will also
If
block
you,
conversion of E4 to T. That's it.
if you give it for total like 6 to 12 months, usually the amiodarone induced hypothyroidism starts after 6 to 12 months of therapy.
So we don't give it that long anyway.
Yeah.
Yeah.
uh,
So can you tell us about the dosage of each of these drugs, carbimazole, methimazole, and propylthiouracil?
so usually the first line drug is methimazole, which has a dosage of like 5 to 40 milligram, depending upon the you titrate it according to the free T4 levels initially, and then the maintenance
Day
dose you
dose or
put.
BD dose?
So it is so it is a BD dose, sir. Like every 12 hours you
Hello.
administer it.
Yeah.
Maximum it can go up to 40 milligrams, sir.
Start with 5 mg or 10 mg BD, and
Right.
then
Yes, sir.
step it up. Yeah. Okay.
Yes, sir. And like if at all methimazole is contraindicated, like in cases of first trimester of pregnancy because of its teratogenic effect, then you go ahead, you can give propylthiouracil, which has a dose of 50 to like it can range between 50 to 150 milligrams, and this has an added advantage that uh, it is one dose administration can be done for this, and like yes, sir. And like
Carbimazole.
so carbimazole is also along similar lines, sir. Like in compare like same as methimazole, sir. Uh,
It is less effective compared to methimazole. The dosage
Methimazole, yes, sir.
5
The,
mg BD again.
yes, sir. And in addition, we also look at the side effects of these thionomide group of drugs, which includes there could be hypersensitivity, and it could cause pruritic rash. Then there can be features of arthralgia as well, and the hematological side effects. One of the most important, which is rare but dangerous, is granulocytosis, and there can be aplastic anemia as well. In addition, these drugs are also hepatotoxic, which have hepatotoxicity, which can cause jaundice, hepatitis, and liver failure, and increased risk of malformations as seen. It is associated with drugs like carbimazole and methimazole.
What
And sir,
what formation is it?
uh, like malformations, congenital malformations, teratogenic effect is seen with this.
So at the end of 1 week, you are supposed to test for total blood count, TBC, because agranulocytosis is the most dangerous, as we said. That happens very immediately. It's like a almost like a idiosyncratic reaction. So you have to test it early. So in the first week of the medication and LFTs also, so that you know if there is no reaction, then you can carry on safely after that.
Yes, sir. And yes, sir. Like that was about anti-thyroid drugs, sir.
Okay.
I'll go to so then the next option, next treatment arm is radioactive iodine ablation. Uh, this basically means destruction of the thyroid tissue using radioactive iodine, which is usually iodine 131. And because radioactive iodine, it will going to emit two arms, which is the gamma arm and the gamma rays and beta rays. Gamma rays have a diagnostic effect, and beta rays have a therapeutic effect in terms of it causes local tissue destruction. And like indications include like patients who have toxic multinodular goiter or toxic adenoma, and their the scintigraphy or radioactive scan is showing a high uptake. And in cases where there is a failure to achieve euthyroid state, in case of like with the help of antithyroid drugs, which could be because of any refractory disease, or if the patient has developed major side effects to the antithyroid drugs, or if the patient is having contraindications like liver disease. And in case of patients who it can also be used in patients who have a high surgical risk, which could be because of comorbidities like congestive heart failure or pulmonary hypertension, or and in a post-surgical treatment of cancers also, it's an indication. And it can also be used in cases of large compressive goiters, so that you can decrease the thyroid volume like it's similar like in conditions where surgery is not possible. And the contraindication to it includes pregnant females, children under the age of 5 years, and patients like poor compliance.
Just a minute.
And yes,
I-
sir.
You said the indications are toxic nodule and multinodular goiter, but I
Yes,
think
sir.
primary indication is Graves.
Yes, sir. Graves' disease
See, I
as
think
well. Yes, sir. Yes, sir.
toxic nodule, by and large, I don't think so you should offer radio ID. Toxic nodule, multinodular goiters are surgical management. You achieve euthyroid status and then you remove the thyroid, because that is more definitive treatment. But in Graves' disease, I think it is you can either decide to go for radioiodine or for surgery. But again, you have to offer the choice to the patient. But with the solitary nodule and multinodular goiter, I think I don't think unless the patient has specific preference for radioiodine or patient has high risk surgically, and then you can give them radioiodine therapy. Niranjan?
Yes, sir, I agree, sir.
Tanya, what does the textbooks and the papers say? With the
Same thing, sir. Like you said, for radioactive iodine, for toxic adenomas, usually just achieve the euthyroid state with antithyroid medication and then plan for surgery, sir. Radioactive iodine ablation, like you said, is reserved for Graves' disease.
See,
But in practicality, most of the time, these patients, they primarily would have gone to endocrinologists, and most of them,
Yes,
they
sir.
usually refer them for radioiodine therapy rather than surgery.
see the Einass, let us
Yes,
say,
sir.
let us say it's a toxic nodule. What will be the
Yes, sir.
treatment of the toxic nodule surgically?
So like it will depend, sir. Like depending on the
It
size
depends.
of the.
No, it doesn't depend on anything. It is only standard treatment. What is the standard treatment? We know what is the standard treatment for a toxic nodule?
Make the patient euthyroid and thyroidectomy.
Total.
Hemithyroidectomy.
Oh, hemithyroidectomy. You remove the side where the nodule is, and then you have a normal thyroid on the other side. So you don't even need replacement therapy.
Yes.
Correct?
Yes.
But if you give radioiodine, then you have converted the patient hypothyroid for life. So you will have to give them medication. If it is multinodular goiter, then you can still do a subtotal, though nowadays nobody does subtotal thyroidectomy. You can still do a relatively conservative thyroidectomy and then still be residual thyroid tissue, which could be enough to secrete enough thyroid, or you may add small dose of supplementary medication. But if you give radioiodine, then you will have to give them lifelong supplementation of thyroxine. Correct?
Yes.
So that is why, even from that point of view, I think surgery is a better option for toxic multinodular goiter or toxic adenoma. Generally, even in toxic multinodular goiter, there will be one nodule that is predominant and others will be at best bomb nodules. Continue, Ma. Now you have to talk about the dose and the method that is given and everything.
Sir, so there's like this preparation for ablation, sir,
Yeah.
because it is associated with the transient worsening of hyperthyroidism. So you firstly control all of reduce all of the complications, like especially in groups who have various comorbidities. You administer beta blockers, and in addition, you'll administer methimazole or like antithyroid drug, so that you can achieve a euthyroid state. And this has to be discontinued 2 to 3 days before you are starting the therapy. Then further, you also have to make sure that the patient there's not an excessive intake of iodine for at least 1 week before you're starting the ablation. And you also have to make sure you have to rule out causes like pregnancy in females, and you give one single oral dose of iodine 131, sir. And
What is the
like
dose?
one single, so the dose,
They are measured in millibecquerels, no? You know, what is the dose of radioiodine, man?
8 to 12 MCI something.
What?
8 to 12 MCI.
Millicuries
Yes, sir.
or millibecquerel. Becquerel, and they are the Pierre Curie, Marie Curie, and Henry Becquerel. They are the three people who got the Nobel Prize together. Then Marie Curie got Nobel Prize again later. But they are the three people. So you either measure it in millicuries or millibecquerel.
Yes.
So what is the dose?
8 to 12 millicuries, sir.
Are you sure?
Not sure.
These things you should know. I think this is a homework. I'm not going to tell you the answer.
Yes.
If you don't know already. Tanya, do you know the dose? Golden silence.
Hello. So can you hear?
Yeah, what is the dose of
Sir, for Graves' disease, like he mentioned, it is 8 to 15 Marie Curie only, sir.
millicurie.
Yes, sir.
Okay.
But I'll also I'll research, sir. I'll do like find out some new recent article, because this I read long back, 8 to 15.
Okay, Einass, do you know the dose?
no, sir, I did not pay attention to the dose, sir.
You should know.
Yes, sir. Yes, sir. Sorry, sir.
Okay,
So
carry on.
I'll look it up. Yes, sir.
You are saying. So you said that you have to administer dose. Yeah, then what happens?
So there's the uptake by thyroid gland, and I said there's the beta radiation, which will cause destruction of the thyroid tissue, sir. And that is how you go ahead. So there can be complications associated with this, and early complication there can be early complications and late. Early can be gastritis features like nausea, vomiting, and there can be usually sometimes like especially if we see patients with Graves' disease, they could land up in a state of hypothyroidism and could result in a lifelong dependency on levothyroxine post ablation therapy. And there can be other features.
Certainly develop hypothyroidism. That is the
Sir?
purpose. They will almost certainly develop hypothyroidism.
Develop.
You are destroying. What kind of radiation is this? Radioiodine.
So it has two rays, no? So, like gamma rays and beta rays. So beta radiation is what is causing the
types of radiation, you know? What are the two types of radiation? When people, radiation oncologists talk about radiation, what are the two things they talk about? Brachytherapy and teletherapy.
okay. Yes, sir. Yes, sir.
So what is brachytherapy? What is teletherapy? What is external beam radiation? What is brachytherapy? What are these
So-
Brachytherapy.
linear accelerators, the photon therapy, the cyber knife, gamma knife, all these things are what? What type of therapy?
External beams.
Huh? They're all teletherapy, man. From they are you
Yes, so brachytherapy is when the radiation, we keep a
Inside.
instrument into the tissue and then deliver the radiation.
correct. So this is what,
Teletherapy is giving it from a distance, no, sir.
yeah, correct. So what is this radioiodine?
Brag.
Bra-
Or teletherapy only, sir.
brachytherapy.
It is brachytherapy. It is the most elegant form of brachytherapy because the amount of radiation that it actually is supposed to be, for example, if you measure it in, the usual centigrades that we usually measure, it is, for example, what is the normal radiation you give for, for breast or for the rectum and all that is usually 25 to 50 grays. So this will amount to, if you measure it in those terms, 200 or 300 grays. So it would have caused hell of a lot of destruction of surrounding tissue, significant collateral radiation damage. But it hardly causes any radiation damage because of the elegant way it is administered. The only tissues that uptake the iodine are destroyed. The rest of them are not, because the radiation is administered through iodine. That is why there is no surrounding tissue damage with radiation. There may be slight edema and things which will settle down, but by and large, even though the radiation dose is pretty high, the surrounding damage is very low, and that is why it is a very elegant form of brachytherapy.
Here, only the question will be like in radioactive iodine ablation also, there have been controversies where they have tried low dose and high dose.
Correct.
So if you give low dose, the problem will be you have to probably give an additional dosage. And if you give high dose, the problem will be the probability of the person requiring the additional dosage will be lesser, but they will go into hypothyroidism.
Correct. Correct.
So if it in high dose, if it is at the end of 1 year, nearly 70% or more than that probably will go into hypothyroidism. If it is low dose, it will be around 60%.
Correct.
So that is the issue. So that how much is the dosage, you have to tell us.
Homework.
Homework. What is low dose? What is high dose?
Yes, sir. Yes, sir.
Okay. Carry on, ma'am.
Yes, sir. And like in complications, there can be other complications like silidinitis and silidinitis, sorry. And then you can have late complications, which like this therapy can cause bone marrow suppression. So there can be secondary malignancies like leukemia can occur, and it can also cause xerostomia, like dry mouth can be a late complication. Uh, and then so the last one is thyroid surgery, and the main indication for any for the surgery is any thyroid malignancy. Then it is also indicated in cases if that.
No, we are not
Sir?
talking pregnancy, thyroid surgery. We are only talking about hyperthyroidism needing thyroid surgery. Malignancy is a different topic that we'll discuss later.
Yes, sir. Yeah, they can like if there is a large goiter, which is or if there are it is causing obstructive symptoms, like there's a dyspnea, dysphagia, or in case of toxic multinodular goiter, or if there's a retrosternal extension of the goiter, in cases where there is refractory thyrotoxicosis, and these are the conditions where we will consider going ahead with thyroid surgery.
Okay, now
And
give you a scenario. Vinod, patient has significant exophthalmos and eye signs relating to hyperthyroidism. Then you have actually managed to bring the patient to euthyroid state. Does surgery or radiation, radioiodine, which has more deleterious effect on the eye signs, despite the fact that you have achieved euthyroid status. Did you understand the question?
Sir. No, sir. Sorry.
If the patient has eye signs, significant eye signs, orbital, disease, and then you have achieved euthyroid status by giving them medication, patient is now euthyroid. Would you offer them surgery or would you offer them radioiodine?
Surgery, sir.
What happens to eye signs with the radioiodine? What happens to surgery? Eye signs with surgery.
So
Don't-
radioactive therapy can worsen the Graves' ophthalmopathy, no?
Correct. Correct. That is what I wanted you guys to know. See, that is why whenever there is significant eye signs, you are better off offering surgery to those patients compared to radioiodine because eye signs can worsen with radioiodine therapy. With Graves, with surgery, it may not improve. In significant cases, it does improve, but at least it won't worsen. I think that is the answer you should give. Niranjan?
Yes, sir. Correct.
Okay, ma. Talk about surgery.
Continue.
Yes, sir. So these are the indications, sir. And again, preparation for surgery will be including achieving euthyroid status prior to surgery and giving anti-thyroid drugs and symptomatic management and the symptomatic treatment. In addition, you can consider giving you also have to make sure that the patient does not have hypocalcemia and if needed, you deplete the calcium levels and the vitamin D levels as well. And
Specifically,
yes,
apart from
yes, sir.
What are the other specific measures in terms of consent of this patient when you do surgery for Graves' disease or, for example, usually for Graves, but for toxic nodule, toxic multinodular goiters, what is the specific thing in consent and what other precautions do you take? What other things will you reserve for this patient?
So firstly, we will tell them about that there is a risk of nerve injury and they vocal cord paralysis. If
no more
no, sir, if you're going with thyroid, total thyroidectomy, sir, we do mention that, sir.
No, so did you understand sir's question? Apart from the routine, what you do for thyroid surgery, for other conditions,
Yes,
what do you do extra for this?
So I will just give you a clue. When Theodore Cocker used to do surgery, he conquered something for which he got the Nobel Prize. Before that, patients with thyroid surgery used to die left, right, and center due to certain conditions. What is that? You know?
Thyroid storm, sir.
No, not so. Tanya?
I don't know, sir.
Come on, man. This is very simple. What was the scourge of thyroid surgeons before Theodore Cocker started doing something which actually, that is why he got the Nobel Prize. He had some 8,000 series of 8,000 patients, and he controlled something which actually now makes thyroid surgery safe. So, which is why you need to be aware of this. I'm giving you so much clue, nobody is picking it up.
The injury to parathyroid? That you
No, will
routinely
it cause
also
death, sir? Will injury to parathyroid cause
no,
death?
sir, death. No, sir.
What can cause death?
Bleeding,
sir.
Bleeding?
Finally the penny.
And why is it different in hyperthyroid?
Bleeding would be
Vascularity
usually
will
more,
increase.
vascularity would be more.
This decreased peripheral vascular resistance also because of decreased this, so it can cause more bleeding.
I think all those things are physician answers, man. See, as you said, somebody, I think somebody said that gland is hypervascular when there is
Yes.
hyperthyroidism. The gland is hypervascular, so that is why there is bleeding, not because peripheral resistance is decreased. It may cause,
Yes, sir.
but it is because the gland is very vascular, which is why previously when they prepared these patients for surgery, they would give something called leukocidine.
Iodine.
So leukocidine is what? Do you know the combination of leukocidine?
5% iodine plus 10% potassium iodide, sir.
Correct. So that would not only reduce the hyperthyroidism, it will also reduce the vascularity of the gland, which would help to control the bleeding. So which is why you have to arrange blood when you are doing surgery for thyrotoxic patients. And you also consent them for re-exploration, because despite the fact that you have controlled the bleeding on the table, there is a chance, because the gland is hypervascular, there can be bleeding post-operatively, in which case you may have to reoperate. So that is why I asked you specifically what is the consent, change in consent. You have to increase risk of bleeding, you have to take consent for that. And second thing is risk of reoperation, and you have to arrange blood in these patients. Follow?
Yes.
Yes, sir.
Carry on now.
Okay.
These
Yes,
are the
so
oh,
yes, sir. So I'll go ahead, sir.
yeah, please.
Yes, sir. So this was about the treatment, sir. Now, like thyroid storm, which is like it is a state of an acute exacerbation of hypothyroidism, which can result in a life-threatening hypometabolic state, and this is also known as thyrotoxic crisis. And in terms of etiology, there can be iatrogenic causes and stress-related causes. In iatrogenic causes, you uh, sir.
Niranjan? Hello.
Hello, yes, sir.
Is there
Hello.
is there anything they need to know specifically about the surgery for thyroid hyperthyroidism in terms of
I don't, I don't think so, sir. I think we have discussed everything, almost everything.
only thing I would like to add is that when you do the surgery for hyperthyroidism, you use either the bipolar or the harmonic scalpel for dissecting. Every single small tissue needs to be addressed. You can't, you can't do any blunt dissection and what we do for other things. You have to, whenever you do the dissection, everything has to be dissected using a bipolar or a harmonic sphere. I think that is the most.
I think as the modern day surgery for thyroid has moved away from monopolar to bipolar and probably harmonic also.
Yeah.
That is why the results are also better nowadays.
Yeah. Okay. Carry on.
Yes, sir. So in terms of there can be iatrogenic causes, which could be uh, like radioactive iodine ablation, or in case of thyroid surgery, uh, in case of patients using exogenous iodine, which could be the source could be that of a contrast media, or in cases of it could be amiodarone induced, or in case if patients have discontinuation of anti-thyroid medication. Stress related, there can also be stress related surge, which can worsen the pre-existing state of hyperthyroidism, which can be in cases of illnesses like sepsis, myocardial infarction, or diabetic ketoacidosis as well, and in conditions like anesthesia induction, or even labor. Then the clinical features will include hyperpyrexia. There'll be profuse sweating. The patients will come with tachycardia, where the heart rate will be more than 140 per minute, and they can also have arrhythmias as well, atrial fibrillation. Patients will come with hypertension, that will have wide pulse pressure, and they can also land up in congestive cardiac failure. Uh, then, in addition, patient can have hypotension and shock because of secondary to the heart failure, or hypovolemia because of as a result of insensible losses. In addition, there'll be the previously discussed symptoms of thyrotoxicosis, abdominal pain, nausea, vomiting, and patient can have diarrhea as well, and central nervous system manifestations, which could be like agitation, anxiety, delirium, and it can also cause they can also be seizure and coma as well. For diagnosis, we will sir.
You said the patient can have hypotension, and
Yes, sir.
what is it usually due to?
Sir, because of high output, like patient will have heart failure, like there is high output cardiac failure, sir.
Hyperdynamic circulation and severe
Yes, sir.
vasodilatation and pooling of blood in the sinusoid. So that is the thing.
Okay.
More than cardiac failure, it is this. It is usually bounding pulse initially because of the hyperdynamic circulation. And if it persists, what happens is there is significant peripheral vasodilatation and loss of the sympathetic tone and pooling of blood in the periphery, and that causes hypotension.
Okay.
It can also be due to heart failure, I agree, but there is other
Yes, sir.
cause also.
Yes, sir.
Okay, carry on.
Yes. In terms of diagnosis, you will see the clinical features. When going ahead, you will also diagnose it on the basis of your thyroid function test, where you can have a low thyroid function test, like you can have low levels of TSH and elevated T3, T4 levels. Further testing, we need to assess for complications, therefore, ECG to assess for any atrial fibrillation, and liver function test should also be done if if we find liver function tests, and if there's any evidence of jaundice, we should consider that. Then for treatment, for management of thyroid storm, your the approach will be divided into your critical care approach, symptomatic treatment, and anti-thyroid medications and definitive therapy. Here, critical care. So basically, you should consider ICU admission and monitoring, and then you should start symptomatic treatment as well, wherein you're again giving beta blockers as the first line drug, wherein you use propranolol. Because propranolol is preferred because it has a combined effect of beta blocking as well as it has an anti-thyroid effect, and then you can also consider using esmolol, and if at all there are any contraindications to beta blockers, then you go ahead with calcium channel blockers like diltiazem. In addition, patient will come with hyperthermia, so uh, you need to administer antipyretics. You and In addition, you can use external cooling techniques like ice packs and cooling blankets. The other complication that needs to be dealt with is hypotension and hypovolemia. So adequate fluid resuscitation is required, and the fluid requirement is usually high in these cases. And usually you should prefer giving fluid containing dextrose, because it is a state where there is high. It is a state where there is a high metabolic demand as well. And again, you will also have to, if there is any electrolyte disturbances, you consider administrating that. And central nervous system manifestations of agitation, seizure, or and others, you should consider administrating benzodiazepines like clorazepam. And you also treat the concurrent conditions of heart failure or atrial fibrillation which is present. Then you go ahead with the anti-thyroid medications, and the anti-thyroid medications will include, like it includes inhibition of the so this will have three lines, that is you either inhibit thyroid hormone synthesis, which includes propylthiouracil and methimazole, and then you'll go ahead with using drugs which will inhibit thyroid hormone release. This will include giving potassium iodide solution or Lugol's iodine then. And the third arm will be inhibiting the peripheral conversion of T4 to T3. These can be aided by drugs like propranolol, and drugs like glucocorticoids also help in inhibiting this conversion. So go to thyroiditis.
See, just a grammar
Yes,
correction,
sir.
not administrative, it's administering. Okay, so
Yes, sir. Sorry.
it's-
For
how many
thyroiditis,
you got?
sir.
How many slides have you got?
So this is relatively small, sir. Like only includes Hashimoto's and like
I think 4 or 5
subacute.
slides. 4 or 5
Yes, sir.
slides, I think.
Carry on.
Yes, sir. So Hashimoto's, you'll have unknown etiology and immunological mechanisms. Unknown etiology, it could be the genetic factors playing a role. And immunological, you consider HLA, DR3 and DR5. And you have cellular and humoral responses also, which are activated, which is basically activation of B lymphocytes. And like the active B lymphocytes are going to produce the TPO antibodies and thyroglobulin antibodies, which cause the destruction of thyroid tissue. In terms of clinical features, early stages, they could be asymptomatic, and they could only have there could be painless goiter which is present. And in the late stage, the thyroid can become normal size because of the extensive fibrosis which has occurred, and the patient will manifest signs of hypothyroidism. Uh, Going to the diagnosis, you will consider doing the thyroid function test, which will vary depending on what stage it is in. Uh, Here, firstly, you will do thyroid, and early stages, you can have elevated T3, T4 levels and decreased TSH if at all there is Hashimotoxicosis present. And as it progresses, like in the early phase, it can have subclinical hypothyroidism where there is mildly elevated TSH and normal T3, T4. And in the late stage, there'll be overt hypothyroidism where there is high TSH and less T4, T3 levels. You'll see the thyroid antibodies, anti-TPO antibodies will be positive, and thyroglobulin antibodies can also be positive. And other lab findings you need to consider is CBC, which can show mild anemia, and there can be increased levels of ESR seen as well. So this is like the diagram which is showing the features of thyroiditis. And in addition, so basically here the lower half of the tissue is appearing inflamed. There is a lymphocytic infiltration which is seen. And in addition, there are a lot of congested blood vessels, and lymphoid follicles are prominent with a germinal center. And it is indicating like there's a visibly inflamed region which is seen uh, in the greenish area. So the histological picture of this of Hashimoto's thyroiditis. Then going to subacute granulomatous thyroiditis, there can be this is the one is Diquerin's. Sir,
Go back to the
sir,
previous, go back to the previous slide.
yes, sir,
See, if you want to put up any slide like this,
yes, sir.
you should know what to say. Otherwise, don't put it up, because I don't know what this green area indicates. And I think you should know what are the features of Hashimoto's in histology. Otherwise, don't put up a slide like this. Because if you put it up and not say the correct things exactly like what you're supposed to say, it is inappropriate. What is this
Yes, sir.
green? Anybody?
Sir, so here in this image, like the lower half, it is showing like an inflamed image of thyroid, and like there are lymphocytic inflammation which is seen, and like the arrows are indicating congested blood vessels, sir. Then you have the orange area with, like, here in comparison to here, the orange area which is being demarcated, that is the lymphoid follicles with a germinal center, and it is surrounded by a hypercellular parafollicular region, sir. So the which is showing an extensive sign of inflammation, sir. And the normal thyroid tissue, the top part is the normal thyroid tissue, uh, which is shown in the upper part, sir. Like there is
What
no absence of inflammation which is seen. Like there's absence of inflammation there.
what is
So
the
like
difference between the first? What is the difference between the first and second? Is there like different stains have been used? Why
no,
is it
sir.
looking orange and greenish and
No, sir.
bluish?
Sir,
This is
so
the
like
normal.
this is the normal one. Just to demarcate the regions here, it's basically just highlighted, sir. Like this the this is the normal picture which is being seen in the slide. Here the basically it's like I, like highlighters or marking points to just show what is the
Okay.
feature which is seen, like that, sir.
Okay.
So
Okay. Okay.
like lymphocytic infiltration, then lymphoid follicles with germinal centers, and like this overall destruction with congestive blood vessels. These are the characteristic histopathological features which are seen in Hashimoto's, sir.
Okay.
Yes, sir.
Go on. Go on.
Yes, sir. So then you have subacute granulomatous thyroiditis, which is also known as de Quervain's thyroiditis. This is characterized by the damage to follicular cells, and there'll be appearance of like a multinucleated giant cells here, and there'll be formation of granuloma and fibrosis as well. In the clinical features, the patient will come with like there could be a possible past history of upper respiratory tract infections. These patients will be having painful firm goiter. In addition, fever or malaise can be present, and again they'll be having features of hyperthyroidism followed by features of hypothyroidism. Usually, like the inflammation of thyroid gland, there'll be manifestation in three phases. So you'll have the thyrotoxic phase, which is causing which which is caused by the damage of follicular cells, and there'll be a release of stored thyroid hormones. Then there'll be a hypothyroid phase, where there'll be because there's a depletion of the preformed colloid, and there'll be impaired synthesis of the thyroid hormones. And finally, once the thyroid function test recovers, there'll be features of euthyroid state. In the other variant is subacute lymphocytic thyroiditis. In case of subacute lymphocytic thyroiditis, the causative factors could be so there is, again, here it is characterized by damage to follicular cells, and the features could resemble Hashimoto's thyroiditis, and the causative factors includes drugs which could be lithium or interleukins 2. It could be various autoimmune diseases, and like it can also be due to in the postpartum period, like there'll be postpartum thyroiditis, and usually postpartum thyroiditis, it will be prevalent in women who have type 1 diabetes mellitus, and they'll also show increased levels of thyroid peroxidase antibodies. The clinical features for subacute lymphocytic thyroiditis will be painless firm goiter, and this will also be characterized by the features of hyperthyroidism and followed by features of hypothyroidism. In case of thyroid function tests, we'll depending on which phase it is in, you can see thyrotoxic phase and hypothyroid phase. The Again, thyrotoxic phase will have decreased TSH, increased T3, T4 levels, and hypothyroid phase will have the decreased T3, T4, and increased TSH levels. And the confirmatory, like ESR levels, will be increased, and which can be considered as a confirmatory test. In addition, the uptake study, if done, there'll be a decreased iodine uptake in this, and you'll also have ultrasound. Here, the ultrasound will show there'll be poorly defined hypoechoic regions which will be seen. There'll be decreased vascularity, and there'll be a sort of cobblestone appearance. And histology wise, we can differentiate between these two conditions. There'll be subacute granulomatous thyroiditis, there'll be multinucleated giant cells and granulomatous inflammation. And in case of subacute lymphocytic thyroiditis, you'll have lymphocytic infiltration with uh, sparse germinal centers. Uh, so, uh, like here in this again, we can see subacute granulomatous thyroiditis, where there is granulomatous inflammation and there are multiple multinucleated giant gel cells which are seen, and you have subacute. This is a subacute granulomatous where there's a non-caseating granuloma with inflammatory cells which is seen, and the other picture is that of subacute lymphocytic infiltration where there is a lymphocytic infiltration which is seen. So that's it. That is what I had included, because treatment again will be it will be similar to depending on hypo and hyperthyroidism, whatever state they are in. So
Symptomatic treatment. Any role for steroid treatment? Homework. Already 10 o'clock. So,
yes, sir.
apart from treating, as you said, hypo or hyperthyroid features, is there any role for any other symptomatic treatment in either Thyroiditis or subacute lymphocytic thyroiditis?
Um,
We'll talk about this Thyrotoxicosis and some, what is that? Very woody thyroid. Where do you get that woody thyroid?
So
Turn to hard thyroid, which can compress on the trachea and cause scabbard trachea.
sir,
What is scabbard? You know what is scabbard?
no, sir.
What is the shape of the thyroid? Is the trachea? What is the shape of trachea?
Scabbard is like those small swords or dagger, what you call. They had a sheath that is called scabbard.
Case of a sword or a dagger. So, what is the shape of the trachea usually?
It's cylindrical.
Cylindrical, or sometimes it may be semicircular in the front and flat in the back.
Yes, sir.
But if the gland is so tough and it's very, it can compress the trachea and make it look like a scabbard. So that is very classical of what thyroiditis?
Riedl's thyroiditis.
Riedl's thyroid. What is Riedl's thyroiditis?
It is a fibrosis, sir, generally.
It causes more fibrosis.
Yes.
So she didn't talk about Riedl's thyroid. I don't know whether Riedl's and subacute lymphocytic thyroiditis are the same. Is it, Einass?
No, sir. I have missed out on Riddles, but sir, but they are not the same, sir.
Not the same.
Riddles.
That is why I asked.
Yes, sir. Riddles is more of an autoimmune disorder. If there's any IgG related diseases, sir, autoimmune pancreatitis or anything of that sort, that is what is associated with Riddles.
In the group. Okay, you mixed Riedl's thyroid.
Yes, sir. So I've missed on Riddle's thyroiditis, sir.
Right.
You all of you can write take it as a homework also. Riedl's thyroiditis.
Yes, sir.
And one more question: what is MBQ with respect to radiation? This thing, iodine radiation. Does anybody know?
I told them already, Niranjan. I
Milli-
think.
So
Milli-
millibecquerel.
Forgot. It is not milli.
Then
It is mega.
Megabacter.
okay, sir.
Megabecquerel.
So it is 8 to 15 mega only, sir. Mega
No, no,
curie
no,
units.
no. 8 to 15 MCI is right.
MCI.
That's why I was asking about MBQ. What is 8 MCI relate to in respect to megabecquerel, and what is 15?
Yes,
Low and high.
I'll find out, sir.
Yeah, that is homework. Yeah, sir. Comment, sir.
I think, Einass, your class this time was much better. Definitely, your presentation is improved. You didn't use going ahead many times, which is good. I think otherwise, understanding the topic is also pretty decent. Still needs to be more clarity and more fluency, which will come. So I think all in all, good. Content was good.
Sanya, anything else? Any comments?
Same, sir. Compared to our last class, there is much more clarity in our class today. It was good, sir.
Yes. Okay. So if there are no more questions, I think we'll conclude, sir.
Yeah.
Yeah. Thank you.
Thank you.
Thank you.